Okay, here we are with the Immunology Exam 2 review. Today I'm going to take some time to go over everything we've learned the last couple of weeks and touch on some highlights of it so that you have an easier time trying to wrap your head around all of this material. So what does this exam all cover? Well, we started with complement, moved on to agglutination, we did some labeled immunoassay, some molecular diagnostics, hypersensitivity, and the autoimmune disorders that we did this week in the laboratory. So I'm going to walk through each of these and tell you where to concentrate. So here's complement. Now, of course, in a multiple choice exam, I'm not going to ask you to draw the complement cascade. But what I do want you to know is what starts each pathway, what factors may be included in each pathway, know what the C3 and C5 convertases are in each pathway, and know what happens when this whole entire sequence is done. So obviously, it starts with some type of a foreign invader. Could be just the microbial cell surface itself, the antibody binding to an antigen on a cell surface. This whole cascade of events has to happen in order for the cell to lyse. If any of those pieces are missing, you're going to be more apt to get bacterial infections that are going to get out of hand because you're maybe missing one of these complement components. Now, there are some complement components that are more important than others because they have a very large role to play. So when you look over on the right side of the screen here, you can see that I have included all of the important pieces. So if you can memorize the fact that C3 is in the greatest abundance, it's the major component, it's where the complement cascade reaches its maximum speed and activity. A deficiency in that would obviously cause great clinical symptoms. Those types of things. Complement components are made in the liver. So I have everything on this list that you need to memorize about the complement cascade. If you're struggling with any of these, I say make note cards and study your tail off. You're going to see probably a good 5 to 7 questions just on this screen alone, but they're all included here, so make sure you know it. I have a little bit about the alternative cascade only because I couldn't fit both of them on one screen. But same thing as the last slide. I have everything here that you would need to know. Great note card material. If you're not a note card maker, you may want to consider being one because it's a great way to use process of elimination. Make a note card that says what component starts the alternate pathway. On the other side says C3. By the time you've seen that card 20 times and you know it, take that card out of the stack and only study the ones that you struggle with. By the time you walk in to take in your test, hopefully you only have a couple cards left. So this again covers the alternate pathway, a little bit about the mannose binding lectin pathway, and why complement components would be increased or decreased. Usually they're elevated if you have an inflammatory process going on. They can be decreased if it's been recently activated, if it's currently being consumed, or you have an actual genetic defect. Know about the 2 tests for the classical and alternate pathway. Pretty easy to memorize. AH50 is classical, CH50 is classical, AH50 is alternate. Now they start with what they are, so that's not too bad, right? All right, so let's look at agglutination. I have some fun pictures here to kind of help you with this one. Know the difference between precipitation and agglutination. Now, I had some students really get kind of confused with this. Precipitation involves a soluble antigen and a soluble antibody. So picture the rain outside. It's precipitating, right? Because precipitation is rain. It's all soluble. It's all, I don't want to say melted, but anything that would be inside of a raindrop or in the water is like floating inside of it. So that's soluble. Soluble antigen, soluble antibody. You mix the 2 liquids together and oh, look at this. All of a sudden, that agglutination process starts to cause a precipitation, which looks like a fine agglutination, but you're using soluble and soluble. Agglutination is a big reaction where you have beads or RBCs that are coated with the antigen, and the antibodies come in and create a very visible agglutination. So you have that extra piece in there where precipitation, soluble, soluble, the agglutination has some type of a carrier piece to it, okay? Know what those 2 stages are of agglutination, sensitization and lattice formation. First, you have to sensitize everything. Antigen and antibody has to bind. And then you have a lattice where all the antibodies start to intertwine and create that agglutination effect. Sometimes it's a difficult thing to do. We have this thing called zeta potential around the RBCs. Those RBCs tend to want to repel against each other because they have negative charges. If you ever take two negative magnets and try and push them together, they're going to repel each other. That's what RBCs do. And sometimes we don't want that. We want the antibodies, if they're there, to react. So there's some things that we can do to overcome that zeta potential and enhance that agglutination. We can centrifuge it, because that forces them together. We can use enzymes, which can help strip that negative charge, and colloids as well. And then we also use something called anti-human globulin. This is something that you would have used week 5 in your lab when we kind of practiced the blood bank type of reaction. You had blood cells in antisera, you incubated it, you washed your cells, you add the anti-human globulin, okay, and then you centrifuged it again. What that does is it adds an extra layer of antibodies so that you can get the agglutination to happen if it's there. So you can see on the left-hand side, I kind of found a picture. You've got immunoglobulin coating these cells, but they're not quite creating that lattice, right? So if we add an anti-antibody, okay, those make the antibodies stick to each other. Now we've created agglutination. Okay, so sometimes we need that. Know the difference between IAT and DAT. Okay, indirect antiglobulin tests and direct antiglobulin tests require anti-human globulin. But IAT happens in a test tube and DAT happens, they're bound to the RBCs in the blood in the body. Know the difference between the graded reactions, okay, kind of the definitions. So if 0, it's pretty smooth. If you look over on the right-hand side here, it's all homogeneous and mixed back together. Moving all the way up to a 4+, where you have one solid aggregate clump. Okay. Sometimes we can confuse agglutination with rouleau. We can call it pseudoagglutination. And what happens is if someone has some underlying disorder like multiple myeloma, something that's causing an increased sludging of the blood per se, because those extra proteins are stripping that zeta potential, we can see rouleau. And I have a picture of that over here. It looks like stacked coins. And that can get pretty dicey and kind of look like agglutination, so it kind of takes a trained eye to get used to that. Next, we learned about labeled immunoassays. With these immunoassays, we usually are trying to detect one component of the other, either an antigen or an antibody. And we have different ways of doing this. So we use competitive chemiluminescence sometimes to look for that. This is where a fixed amount of labeled antigen competes with an unlabeled antigen from a patient specimen for a limited number of antigen antibody sites. So they fight over them. The amount of light that's emitted is indirectly proportional when we do that. Okay. We also have sandwich immunoassays, and I have a picture of a sandwich ELISA over here on the right. This is where the sample antigen binds to an antibody on a solid phase. A second antibody is added, and we get a chemical reaction to happen. And this is where the light is directly proportional to the antigen. Okay, so it was indirectly proportional in the last example. This one is directly proportional. So when we talk about enzyme immunoassay, we're typically using enzymes to create a color or a light type of reaction. These are great tests. They have a high amount of stability. They have extreme specificity because these antibodies are very specific to the antigens that we're looking for. They used to use something called radio immunoassay a long time ago. And by a long time ago, I mean, I think we had one at the lab that I worked at, my very first job. It was about 20 years ago. And we had a radio immunoassay analyzer. We did testosterones on it. There was one tech that would sit in a lead room, okay, because they didn't want the radiation to get through. They had to wear one of those little radiometers on their name tag to make sure that if they were working in there too much and they got exposed to too much radiation, they wouldn't be able to work in there the rest of the week or something along those lines. So needless to say, that doesn't really exist anymore. I think they use radioimmunoassay in research at times, but that is not something that we typically see anymore because enzyme immunoassay is very specific and much safer. Okay. All right, then we have immunofluorescent assays. With this, we're looking for a fluorescent type of reaction to occur. Now, what this would look like under the microscope, if we were to do a slide test for this, you'll see the ANA patterns later on, and it's a very similar look under the microscope. But what the immunofluorescent technique does is we use a labeling antibody with a fluorescent compound that has an affinity for proteins. It reacts with that antibody-specific antigen. It's very highly specific, and we'll get that detectable product. Two main ones can be seen here, a direct and an indirect immunofluorescent assay. So with the direct, you can see that there's an antigen coating the slide. We have an antibody, and then it directly, with the enzyme, that creates a detectable product. Okay, so we're adding the antibody with the enzyme to get a result. It's very direct. Okay, this is a fluorescein conjugate that's on there. Keep that in mind. On the indirect, we've got antigens on a slide. We add an antibody with a secondary antibody, which contains the enzyme, add the substrate, and get a product. So with the direct, we have an extra step in there. Now, all of these tests use certain types of labels, and what I want you to try and memorize, this is good board stuff, are the types of enzymes that are used for these labels. Alkaline phosphatase, well, that's the ALPO that we talked about in clinical chemistry, right? Horseradish peroxidase, that one, just think of horseradish that you put on your sandwich, right? So these are sandwich assays. And beta-galactosidase. These are things that you're going to have to be able to recognize, for example, at a test question when it says which of the following might be a label used on immunofluorescent assay. Then we had some emerging techniques. We have some quantum dots that, they use crystals, nanocrystals for fluorescent labeling reagents. There's SQUID technology, which stands for a superconducting quantum interference device, that we use to detect a tagged antigen-antibody complex. There's luminescent oxygen channeling immunoassay. This is used quite a bit in our new DADE analyzers by Siemens. And this happens when particles are really close together. Oxygen moves from the sensitizer particle to the chemiluminescent molecule, where we get a luminescent signal, which is like a light per se. And then finally, fluorescence in situ hybridization. This is a really cool technique where DNA technology is used to look for a specific nucleic acid sequence. In essence, the fluorescent molecules are used to paint the genes. So I have a little paintbrush up here showing the fish. Okay, so it doesn't look like a fish. It's a chromosome, actually. But if you remember, when I was a kid, we'd go to the pet store and they had painted fish that you could buy. And I'm pretty sure they don't have this anymore, but actually fish, they'd have paint on them. Okay, they're like neon paint on the sides of these actual fish you could put in your fish tank. So it was easy for me to memorize this because I remembered those fish. But if you picture the whole entire gene being painted, okay, and it ends up turning out like this. If you look at the chromosomes down in the bottom, they're painted some pretty colors. Whoops. All right, very, very, very little on molecular diagnostics, okay? I want you to know that we use PCR, or polymerase chain reaction, to amplify DNA. We use primers to make multiple DNA copies. So we start with the DNA, piece of DNA, which is the top part here. We pull it apart with heat. We add primers and create 2 more strands. We keep doing this over and over and over again to multiply that DNA, and we look for a sequence of the DNA that's in question. So for example, if we're looking to see if somebody has MRSA, we can run it through a PCR type of analyzer where it'll keep heating it up and separating it and annealing these primers, and it'll do that over and over and over until it picks up the sequence that, okay, this is there. And it means that we could tell somebody they have MRSA within 2 hours rather than 2 days. So that can have a profound impact on the healthcare arena because they can keep a patient away from the other patients by putting them in isolation if they do in fact have MRSA. All right, next we talked about hypersensitivity. 4 types, okay? You need to know the information that I have here. If you're really struggling, if you know what I have on the left, that's a great start. Type 1 is an allergic anaphylaxis and atopy. Atopy is just another word for allergy. This is where you see your hay fever, food allergies, things like that. It's considered an anaphylaxis at times, which is the most severe type of allergic response. I have a little girl that lives next door to me, and if she eats anything with dairy, she'll have this anaphylactic shock type situation. And that lovely IgE we learned about earlier is responsible for that. It binds to those mast cells and basophils, and they release that histamine. With this, I'm going to add the hives. Make sure that you know another term for hives is urticaria. Okay. All right, they have type 2. This is antibody dependent, complement mediated. It's IgE, cytotoxic. We see autoimmune hemolytic anemia, transfusion reactions, hemolytic disease of the newborn with this one. Type 3, we've got immune complexes. This is where we see Arthus reaction. Immune complex disease can be called an Arthus reaction. Farmer's lung, lupus. There's an immunoassay test that we can do for these. And the last one, type 4, is cell-mediated hypersensitivity. This is where I think about how allergic I am to nickel. If someone gives me fake jewelry, okay, like really cheap jewelry, and I put this on like my wrist or my ears for earrings or a necklace, I'm going to get so itchy and scratchy. I'm going to be able to stand it maybe for like a wedding, but then I'm going to have to like totally take that off and put it in my purse because I'm so itchy I can't stand it. And that's usually from the cheap nickel and stuff that's in it. But that would be T-cell dependent. Okay, TB skin test is a perfect example of that, but that one is delayed. So number 1, allergy. 2, antibody, because the second letter of the alphabet's a B. 3, immune complex. Okay, the third letter is a C. The fourth letter in the alphabet is D, delayed. Okay, so like I said, I can keep that on for a little while, and then all of a sudden after a bit, delayed response. It's going to make me itchy if I wear that jewelry. All right, next we have autoimmune disorders. Autoimmunity is where the antibodies are directed against one's own tissue due to a failure to recognize self. We see major histocompatibility involvement and tolerance with that as well. We have organ-specific and mid-spectrum diseases. You have to know what disease affects what, okay? So Hashimoto's is considered a thyroid issue. ITP is a platelet issue. Multiple sclerosis, central nervous system. Myasthenia gravis is the muscles. Diabetes is the pancreas, and Graves' disease is also the thyroid. You need to know each of those, okay? A lot of different factors can affect this. It can be genetics, it can be age, UV radiation, many different things. But the biggest immunopathologic mechanism, especially with lupus, is the immune complexes that are formed. It can cause multiple organ issues. The biggest test we can do to look for a few of these is the ANA, the anti-nuclear antigen. This is actually positive in 99% of lupus tests. So that brings us to lupus, right? So lupus is an autoimmune disease. A couple different types. You can have discoid, which is just a rash. It can be drug-induced. You can have a mixed connective tissue issue, or the majority are systemic. It affects the skin, the joints, the lungs, the kidneys, the heart. So if we look at this lady over here to the right, or it could be male, I guess, one of the big things that we notice, and you may have noticed if you know somebody who has lupus, is that rash, the butterfly rash on the face. It covers the cheeks, across the nose, and then to the other cheek. We have heart issues. There's lungs. You can have pleuritis and pneumonitis. With the kidneys, we see blood in the urine. Okay, if any of you guys are in urinalysis, you noticed that this week in the case studies. We can have hair loss, high fever, muscle and joint issues. Okay, a lot of different things with that. Circulating immune complexes, as I just mentioned, is the main mechanism responsible for lupus. It's antibodies to the nuclear components, and we're going to see on the slide coming up next what happens when those antibodies with the fluorescein conjugate are added to those cells. If somebody does have a positive ANA, the doctor is going to think, okay, they got the butterfly rash, they got heart issues, maybe blood in the urine, a few different things, kidney involvement. The ANA comes up positive, they're probably going to do an anti-Smith antibody, or a Smith antibody as well. This is very exclusive to lupus. Some of the other diagnoses, we have anti-DNA antibodies. We have breakdown products of C3. We got increased IgG and IgM. And then we can look at the the ANA patterns. With these, after we do the direct immunofluorescent, okay, so we're putting this on a slide. If we look under the slide and we have the cells and there's a homogeneous pattern. So in the top one here, you can see these cells have very green throughout. Oops, that's what happens. I click on stuff too fast. This is very, 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 very suggestive of lupus. It could be rheumatoid arthritis. When you see homogeneous, think lupus, okay? Same thing with speckled. Both of those could definitely mean lupus. Peripheral is the next one. Those are antibodies to the DNA, and that's usually found in lupus or Sjogren's. Speckled, again, presence of antibody to the nuclear antigen. It's highly specific for lupus and Sjogren's. Okay, so it could be both. They have a nucleolar pattern next. Okay, that's present in 50% of patients with scleroderma, Sjogren's, and lupus. And then the anti-centromere isn't one that we talked about a whole lot in lab or anything, but this one is seen in scleroderma. So with the lupus, homogeneous and speckled is pretty suggestive. Obviously, lupus can be found in any of them, though. All right, the last thing we're going to talk about is rheumatoid arthritis. Very disfiguring and very painful. It's usually more males than females, where lupus, which I should have mentioned on the last slide, it was underlined, is females. Okay, especially black, young, premenopausal females with the lupus. With the rheumatoid arthritis, it's more males, and it begins a little bit later, 30 to 50. We see a shortened lifespan. It's considered a systematic autoimmune disorder, and it attacks the joints. The first thing that happens is we've got the initiation of synovitis, where your joints are kind of starting to hurt, right? Then we have events that turn into an initial inflammatory reaction, and it transitions to an inflammatory reaction in the synovium, where we actually have a destructive tissue process going on. So we see fatigue, anorexia, weakness. We have morning and aching, stiffness that gets better in the evening, but it certainly is worse in the morning. They're not 100% sure what causes this, but there are extravascular immune complexes, and this could be cell-mediated as well. When we do the testing for this, there's a lot of different things the doctor looks at, okay? There's a lot of rheumatoid factor patients that are not, or rheumatoid arthritis patients that are not positive for rheumatoid factor. It doesn't have a great sensitivity or specificity for RA, so they're really kind of going off the patient's symptoms. The IgM is usually in the patient, but the test that we're doing for rheumatoid arthritis has IgG on latex beads for testing. Some of these patients even have a positive ANA, not all, okay? Then we have a couple different types of RA. We can have Felty syndrome, which is RA with a splenomegaly and leukopenia. You can have a high titer rheumatoid factor, positive ANA and rheumatoid nodules, and a high level of immune complexes and low complement. So that's pretty serious. And then a really sad one is juvenile RA. This happens in childhood. And my daughter's 8 years old. She plays travel softball, and she's got a little girl on her softball team that has this. And once they keep her in the game for too long, she starts to get really, really sore. And she's got these little stuffed animals that have ice in them that she's always got on her joints. So I always think about this when think about her when I'm teaching about this. It's kind of sad. All right, well, that completes our review for this test coming up this week. I covered every single question that's on that test. It is on these slides and in your study guide that I'm going to send. You're going to notice that the study guide matches the screenshots that I have on here. I just wanted to talk about it and add some additional pictures. That's why I put it in the PowerPoint form. It's going to be all multiple choice this time, no fill in the blank. And make sure that you're making your note cards and you're staying on task with that, and you'll do great. If you have any questions, certainly let me know.